So, hi, and welcome everyone from Spectrum International. It is a pleasure to have two of the finest contact lens fitters, Mr. Randy Kojima, which he educates at Pacific University, and he also is one of the best contact contact lens fitters, and is very, very well known with topography. And as well, we have Dr. Damati with us. He will be sharing, and he's a really good contact lens fitter as well. So without further ado, please, Randy, go on.
Okay.
You have the floor.
Okay, great. Thank you, Ricardo, and thank you to Spectrum International for setting this up, where Dr. Donati and I can share with you some experience with a couple different lenses. I hope everybody's doing well, and it's a real pleasure to be able to speak with you. So I hope this session will bring some value to your understanding of both these lenses and also the challenges that we face with the irregular eye. I'm going to start by just explaining some of the technical aspects of the lenses, and then Dr. Donati is going to give us a case, which should be really cool to see. So let's get started and talk about fitting the irregular cornea with both.
Sorry.
Oh, sorry. Did I not share my screen? My apologies. That would help, wouldn't it?
Yeah. So.
Okay.
Yeah. So there you go.
Sorry, everybody. My apologies. Okay. Let's begin. Okay, so we'll talk about using corneal GPs for the irregular cornea, as well as using scleral lenses for these diseased, asymmetric, and very challenging eye shapes. Now, with corneal GPs, why is this patient so easy to fit? Why is it technically relatively simple? And this is a 3.5 diopter corneal astigmatism. If you think in terms of millimeters of corneal astigmatism, then it would be about 0.7 millimeters. So relatively high, but it's really not a big challenge in fitting corneal GPs. Now, why? And part of the reason is that the cornea is so regular. Of course, you have a defined flat meridian, you have a defined steep meridian, they're 90 degrees apart. When you look at the elevation map, what you see is the cornea is high where you see red, the cornea is low where you see blue. So it's very easy to align a lens to those high points, the red, and then 90 degrees apart, align it to the blue. Makes it relatively simple. So if we were to build a rigid contact lens for this patient, of course, the landing is going to be heavy along the flattest corneal meridian. You see it landing down at 3 o'clock and landing down at 9 o'clock. So edge lift, landing, apical clearance, landing, edge lift. Now, across this meridian, this is always the easiest because that's where the lens is always going to land the hardest, where the elevation of the eye is the highest. And somebody might need to mute in the background. I can hear a little background noise. Okay, so we've got the lens landing at 3 and 9 o'clock. It's going to have its point of touching down on the eye surface. Then along the vertical meridian, this is where things may get a little interesting, where the cornea is steeper, where the cornea is deeper. So if we were to build a symmetric landing lens for an eye that's very toric, 3.5 diopters of corneal astigmatism, you see a massive amount of fluid at 12 and 6 o'clock. So underneath this point, there's about 80 microns of fluid. Underneath this point, there's about 80 or 60 microns of fluid. So that's a lot of room for the lens to rock back and forth, to be unstable, to be moving excessively, to be uncomfortable. Well, what do we need for this patient? And of course, to be able to resolve how much fluid is underneath the lens along the steep axis, we really need a toric. And you can see that in this lens. Here's your symmetric lens placed on this eye. It has good alignment across the horizontal because the lens is touching down. You can see laterally, it's very stable. But vertically with each blink, we can see a lot of lens movement. We can see some tilting of the lens. We really could have a better relationship. So what we're going to do is build a toric lens that has two distinct meridians of height, one across the horizontal and one across the vertical. So two completely different radii of curvature. Now, when we build that lens with those two distinct radii, we create the same type of rules where we want the lens across the horizontal to land down at 3 and 9 o'clock. But then across the vertical, we want to have a different relationship. Instead of having 80 microns up here and 60 microns down here, we want somewhere in the neighborhood of about 20 microns. The idea being if the lens has just a tiny amount of room to move, both with the blink and to create good tear exchange, then we'll have a healthy fit. But if we don't have so much room for the lens to rock back and forth, then we're going to have a more stable, a more comfortable fit. So that's the same patient now wearing a bitoric corneal GP, and we can create a very good relationship for this cornea because it's such a symmetric eye and because it has two distinct axes 90 degrees apart, flat meridian horizontal, steep meridian vertical, the two 90 degrees apart. We build a toric landing lens, and of course we can create this ideal lens to surface relationship. So then when we face the keratoconic or the irregular cornea, why is it that we have more of a challenge with this eye? Is it because the eye is steeper? Is it because the eye may be more astigmatic? Really, it's because the eye, of course, is asymmetric. So this hemisphere doesn't match as a mirror of the inferior hemisphere. So one side of the cornea is just not at all similar to the other side. And the same thing is true laterally as well. So when we pull up the elevation map, what we can see is the eye is relatively high across this red region, whereas relatively low at 6 o'clock. So we may have some luck aligning the lens across the red most of the way across, but we may have some trouble with how depressed, how low in height the inferior cornea is. So the red is kind of like the mountain, and then you're going from this high elevation of the mountain down to this lowest point, dropping into the ocean, dropping in height, dropping in elevation. Well, to understand the elevation map, it's kind of tricky for most of us, especially when we're starting out with understanding topography. And what the elevation map does is it places a sphere, a best fit sphere, that's meaning a radius that's closest to the radius of the entire cornea. And it's going to align that radius to the anterior surface. So you see the yellow line here would be our best fit sphere. We're going to align it to the center of the cornea and then observe wherever the tissue is on the left side of the line. That means you have corneal elevation. Where you see the tissue below the best fit sphere, in other words, on the right side of the line, that's where you have the corneal surface dropping in elevation. It's creating like an abyss, like this hole, so to speak. So red is where the tissue is on this side of the line. You can just see that at the top up here. And then down below, we notice our sphere is well above the corneal surface. And that's creating the blue that you see here. So the eye has asymmetry, and that's what makes this patient a bit of a challenge. Now, one of the ways to tell, should I fit this patient in corneal GP, or should I go straight to scleral? This would be a helpful understanding. And what you're going to do is go to the elevation map in your topographer and go to the point of greatest elevation that coincides with the point of least elevation. What I mean by that is take this axis line around the clock, find the point where the hot is the hottest, opposite the cold being the coldest. So what I mean by that is you see that line on the graph being most separated in height. And it looks like across this meridian, when I take this axis line around and go radially, we see that we have the biggest change from elevation to depression along this 105-degree axis, roughly. And then you're going to click your cursor in the red, and it says plus 103 microns. Next, you're going to go down to the blue and find the depression, minus 197 microns. So the absolute change in height is 300 microns, meaning that you have an absolute change in elevation from the high point to the low point of 300 microns. Now, what does that mean? Well, when you're below 350 microns of elevation change, so 350 microns of elevation change, if you're less than that, then generally a corneal GP can work with great success, about 88% of the time. When your elevation differential is greater than 350 microns, that's where corneal GPs fail more. The red bars are your successful corneal GP fits. The green bars your successful scleral, meaning we couldn't fit a corneal GP. We tried, but we needed to fit this patient with the scleral. So what do you understand? You know that when you go to that elevation map and you find the height differential, when it's less than 350 microns, about 88% of the time, a conventional corneal GP will work. When it's above 350 microns, you are more likely to need a scleral lens. It's really going to be hard to align a small corneal lens to a very asymmetric surface. So one of the ways that you can approach the irregular cornea is with a dedicated irregular corneal lens. And I know you're very familiar with that. I've been to Saudi a number of times, and I've seen some of the challenging irregular corneas that you face in the Middle East. So how do we best fit these eyes? Well, going slightly bigger is one of the ways to help along the way. Larger lenses create more stability creates better centration and stability creates better comfort. So the KBA is a lens that we use as the corneal GP for irregular corneas. And let's see how this is fit. So across the flattest meridian of the eye, the meridian that has the highest elevation on opposing sides, we can see the lens landing down at around 830 and around 230 right here. And you notice with the way this lens is designed, you get this very wide, soft landing. See how the lens comes toward the surface in a very shallow manner, distributes its force over a wide area before creating a healthy edge lift. Now, the steep meridian is the one that's always the challenge. In this case, the vertical meridian. And what we can see is at 12 o'clock, we have about 49 microns of elevation or of fluid. At 6 o'clock, we have about 219 microns of elevation. So this is the challenge, of course, of the asymmetric or irregular cornea, is that it's going to be very difficult to align to a shape that's higher in elevation at, in this case, 1130, but at 530 on the clock face, we have a real depression in the eye. Well, For this patient, because it was a 300 micron elevation differential, we were able to align the lens reasonably well. The elevation map told us that we'd have this broad, red, high elevation across about 2/3 of the eye. So we see that on the fit of the lens. It's aligning across about 2/3 of the lens. And then where we have our real depression in the eye surface, we see the lens vaulting. So for this patient, we were lucky. The elevation differential wasn't too high. The lens didn't catch the lower lid and want to pop out, maybe because the height difference wasn't so great. The lid is holding the lens up. It's tucking the lens underneath the lid, so there's less lid interaction with the edge of the lens. It was a successful corneal GP fit. Now, the KBA was designed specifically for the irregular cornea as a corneal GP for these difficult eye shapes. KBA stands for keratoconus biaspheric, meaning the front of the lens is aspheric, the back of the lens is aspheric. Now, if you look at the eccentricity of the normal healthy eye, you see that eccentricity describes the rate of flattening from the center of the eye to the periphery, how the cornea is steepest in the center, flattest toward the periphery, and that's measured as eccentricity, shape factor, asphericity, Q value. There's many ways that all describe a similar thing. How does the eye change from the center, the apex, to the periphery? And you know a normal cornea will be steepest in the center, flattest toward the periphery, and a normal eccentricity with this topographer is about 0.65. In this case, this patient is 0.64. Very normal. The rate of flattening of this eye absolutely within kind of a normal range. Excuse me. Okay, now let's look at the keratoconic eye, the irregular cornea, and you see a much bigger change between the center, the apex, and the periphery. Notice on the graph here, there's a real steepening at the center and a massive flattening toward the periphery. So that creates a higher eccentricity. This patient has about double the amount of eccentricity that the normal cornea has. So this is part of the challenge that we face with the irregular cornea. The rate of flattening is much different than it is in the normal eye. And then on top of that, you have the asphericity, the asymmetry of the eye. So if we put a conventional corneal GP on a patient with a relatively high eccentricity, we get a kind of acute landing. Notice how the contact lens is aligned in the center, but as you approach the eye, it hits and lands over a narrow surface area of contact. So that would kind of be like me walking up to you and putting my finger into your shoulder over a small area of pressure. You would feel that pressure of that narrow landing point. So that's something we want to try to avoid with corneal GPs, is having them hit over a really acute or narrow point. Now, if you use a high asphericity on a high asphericity eye, then you can distribute the force over a broader area. And that's what you see here. This lens approaches the cornea in a shallow manner. It touches down gently, comes back up and creates its edge lift. So as a comparison, you see the difference between a spherical lens with zero eccentricity versus a high eccentricity lens on a high eccentricity eye. So this is one of the approaches to improve comfort. Now, to fit any kind of corneal GP or any irregular cornea, we need a fitting set, certainly whether it's corneal GP or scleral. So the KBA comes with a 30 lens diagnostic set that you can get from Spectrum International. And that set includes 17 lenses in the lower eccentricity value, 13 lenses in the higher eccentricity value. And the reason for that is you want the lower E value for the more broader range of kind of normal eccentricities, normal irregular corneas. And then when you're facing a really advanced cone, one that's changing very radically from the center to the periphery, then you want a range of high eccentricity lenses. Now, how do you choose the initial lens? That's really easy. You go about 0.6 millimeters steeper than the flat K. So if you have about 45 diopter flat K, then converted to millimeters, that's 750. We're going to go 0.6 millimeters steeper. The initial lens we choose is a 690 millimeter base curve. So a very easy way to start as choosing your initial diagnostic lens. So then when you're looking at normal corneas, the range of eccentricity is typically in the 0.6 to 8 millimeter range. But if you're dealing with the keratoconic eye, they're more typically over 0.8. They're in the 0.9 millimeter range. So that's why you have 0.9 or basically 1 millimeter, 1.0 eccentricity lenses. I said 1 millimeter, I mean 1.0 eccentricity versus higher eccentricity, because all the eyes we face in the irregular cornea are going to be a radical change from the center to the periphery. So try to match the eccentricity of the lens to the eccentricity of the eye. One of the ways you can tell that you've done that is if you have a broad area of alignment, then that's telling you you're matching the shape of the eye surface. So in conventional GPs, we normally expect to see a really narrow area of landing, but we don't really want that. We want the lens to distribute its force over a broad area. So an ideal eccentricity would look something like this, where you have a lens that has that wide, shallow landing, where you have a wider range of thinning of the fluid. When you have a low eccentricity on a high eccentricity eye, then you see a more acute or narrow area of landing with likely a very narrow area of edge lift. So the lens comes down toward the eye surface. It hits over a narrow surface area. We get both a very tight or very narrow area of touch, as well as a very thin edge lift. If we have an eccentricity too high for the eye, so our eccentricity of the cornea is lower than the eccentricity of the lens, then your point of bearing might move in much farther in on the eye surface. You spread the surface area maybe over a relatively large surface, but the problem is that you're going to have a massive edge lift. This is going to be too wide. We're going to therefore have a lens that's unstable on eye, it's sloppy, it's moving too much. So try to create an eccentricity of lens to match the eccentricity of the eye. And you can see how wide the alignment is here. This is a really optimal outcome. Now, the maybe most important thing that you can do is ensure that the lens has the right height. Of course, we know today that we don't want our irregular patients having lenses rubbing on their diseased tissue, that the epithelium has an important role to play in the health of the keratoconic eye. So make sure that when you pull a lens out of the diagnostic set, or when you're ordering your custom lens from Spectrum, that the height of that lens is high enough to clear the diseased tissue. So very important thing. The next thing is edge lift. Of course, we always want in a corneal GP a healthy edge lift at the tip to allow the lens to freely move with the blink. So as it hits the peripheral cornea, it's not going to impinge. We're not going to damage the epithelium. Then also creating healthy tear exchange. And the edge lift, of course, helps the patient to remove the lens. If we don't have that edge lift, then there's nothing for the lid to grab onto. Of course, if the edge lift is too high, then there's too much to grab onto, and the lens is going to pop out very easy. So focus on the edge lift across the horizontal meridian. That's the one that's the most important, because if it's too far off the eye surface, it's going to create a bridge of the lid, and we're not going to be able to hydrate the peripheral cornea here and here, and that's going to create 3 and 9 staining. So when you concentrate on your edge lift, you might want to focus in on how it looks across the horizontal, not so much with the vertical, because of course, with the irregular cornea, we're going to have all kinds of edge lift in that steeper, deeper meridian. So as a way to optimize the fit, make sure that you're creating that soft, wide landing with a healthy, about a 0.5 millimeter edge lift. Then if your edge lift is wider than 0.5 millimeters, then you want to decrease the eccentricity. Your eccentricity is too high. If you've got a narrow edge lift and the lens is touching almost right to the tip and it's over a narrow surface area, then you want to increase the eccentricity of the lens. Now, one of the things that you need to understand with a lens that has a high eccentricity back surface, it's going to, if you change the eccentricity, then you're going to have the height of the lens change. And you can kind of see that here. All 3 of these theoretical fits are a 7 millimeter base curve, a steep base curve. I think that's about a 48 diopter radius. So if we put if we create an eccentricity of 0.8 and a 7 millimeter base curve radius, we get a very high sagittal depth. If we create a 7 millimeter radius and have a 1.0 eccentricity, then our apical clearance, our depth, comes down. If we increase the eccentricity even more, that creates less apical clearance and more edge lift. So if you change eccentricity by itself without changing the base curve, the height of the lens may be inappropriate for the eye. So match the eccentricity to the eye surface, but also steepen or flatten the base curve radius to create the height you need. And Spectrum can help with this calculation. If you put a diagnostic lens on eye and it has the right sagittal depth, but you need more or less eccentricity, Spectrum International can assist with that calculation. So the consultants are a really important part of fitting the KBA with these very difficult eyes. They can help with those fine-tuned calculations for when do I need to change the base curve with an altering eccentricity. But what you need to do as the practitioner is, number 1, find the lens that has the right height over the apex of the cornea and over the irregular tissue. We must know what lens will clear and protect the epithelium. So that's the number 1 goal of using the diagnostic set in your practice. And then again, use your consultants to assist to optimize those fits. Now, let's move on a little bit. Can we be successful with this patient in corneal GPs? And it is very difficult to look at an axial or a tangential map and determine, is this patient too extreme for a corneal GP? Is this somebody we should fit with a scleral? Well, again, we're going to pull up that elevation map and we're going to look at the point of highest elevation plus 325 microns. we're going to find the opposing meridian of greatest elevation change, in this case, minus 280. This patient has a 605 micron change between the highest point and the lowest point. And you remember the threshold of where we expect a corneal GP to be successful is less than 350 microns. And this patient is well over that, almost double. Now, if we were to model the fit of a lens on this patient, just to see, is there a chance of a corneal GP working? We could place the lens on eye in our contact lens software. And you notice you have landing at 3 o'clock, landing at 9 o'clock. We have a lot of apical clearance, somewhere in the neighborhood of almost 50 microns of fluid right here in the center. We need that because you can see the lens is kind of thin over the cone. We have to make the base curve so steep in order to clear over that very high elevated cone. Well, in the steep meridian, when we look at the tear layer across the vertical meridian, you notice the cornea is high. The cornea is really low. There's a ton of fluid right here in the neighborhood of more than 100 microns of fluid. Then we're just above the cone by under 20 microns, and then the corneal elevation just drops off inferior. So for this eye, the cornea is high, the cornea is low, the cornea is really high, the cornea is low. This is a very challenging eye surface to fit with corneal GPs. With 600 microns of height differential, this is a patient that really is a challenge for the corneal GP. We are much better served with a scleral lens. So when you look at the maps together, the corneal topographer can be a great guide of how to approach these eyes. Do I go with corneal GP or do I go with scleral? Does corneal GP have a chance? If so, we know that for the patient, it's much less expense over the course of their wear period, less in the lens, less in the fluids. If we go with scleral, the lens costs more, the fluids cost more over time. So it's nice if we can fit corneal GP more often. And we know that corneal GP patients, an adapted wearer, can wear them forever. They literally wear them till they die. Thankfully, these lenses are so healthy for the cornea that we often find our corneal GP wearers wear them longer than our soft lens wearers do. Now, if we need to go scleral, and of course, it's hard not to choose a scleral lens for the irregular eye because it's so comfortable. Why is the scleral lens so comfortable? It's 3 times the thickness of a corneal GP. It's 6 times the thickness of a soft lens. It's something like 40% bigger than a soft lens would be, and like 1.5 times the size of a corneal GP in surface area. The scleral is huge. So how does a rigid, large, thick contact lens be almost as comfortable as a soft lens? And it's because of movement. You know, if you look at this lens and how little it moves with each blink, that's why the lens is so comfortable. And then in the center, we vault over top of all that irregularity. So the smart lens that we're going to speak about shortly, that, thankfully we've got a case to review, by vaulting over the irregular cornea and using the symmetric landing sclera to our advantage, now we can create a lens that centers, that's stable, that's comfortable, and providing the vision. So a very important piece. So regardless of the eye shape, whether it's slightly astigmatic or normal in shape, and we have ocular surface disease, then we can fit the scleral lens on that eye. If we have an absolutely asymmetric keratoconic, we can use the healthy scleral shape to our advantage, create an even distribution across the eye surface, and virtually anything in between. Any kind of post-surgical, post-refractive surgery is super easy in scleral lenses. They're just not a challenge. And typically, all of these eyes are relatively easy because we see asymmetric corneal shape, but we see healthy or relatively symmetric scleral shape. So the first goal in fitting the smart lens, just like any vaulting scleral lens, is to vault the central cornea, vault through the limbus, and well onto the sclera before you land down in the far periphery. So to choose the initial lens, it's relatively simple. You have a whole range of trial lenses in the smart lens set. You have the largest number of medium and large diameter lenses. The reason being, the patients we're most likely to fit in a scleral lens are going to be the asymmetric, the patients with higher sagittal differential. The more normal eyes that might have ocular surface disease, then we generally fit a smaller number of those. So you only have 2 lenses for the smallest diameter, but the larger diameters, you're going to have more lenses, simply because larger diameters allow you to vault over top of more asymmetry. So the smallest lens, the 15-0, is symmetric in landing. And the reason for that is the smaller you go in diameter, the closer you land toward the limbus, and the more symmetric the scleral shape is close to the limbus. Whereas, as you get larger in diameter, you move your point of bearing farther out. Now you're landing on more astigmatic or asymmetric scleral shape. Then as we go even larger than that, then we're going to land farther out on more asymmetric surface, more toric landing is required. So the smart lens will be symmetric if you're using the smaller diameter, but more toric in landing when you're using the larger diameter. And you can make a small lens toric, you can make a large lens symmetric, but typically the way the set is designed, it should fit about better than 95% of patients as a symmetric for the smaller diameters, a toric for the larger. So how do you choose the initial lens for this wide range of patients that you'll see? And it's really simple. Basically, if you're going to use the largest diameter lens, the 16.5, and you're dealing with a normal cornea with ocular surface disease, a dry eye patient, then you're going to choose a 4,000 micron. If you're dealing with a keratoconic eye, it has more depth. It's a bulging condition. We need a higher depth lens, so you're going to choose a 4,400 micron lens. Corneal transplants are the least predictive in determining the initial diagnostic lens because, as you probably know, transplants can come as sunken grafts. They can come as bulging grafts. So really, you never know where to start. But what we do is go with a much higher depth lens. If our lens is vaulting the eye by a lot, we can just calculate the drop in depth we need in the custom order. What you don't want to do in diagnostic lenses is put a lens on with touch. If the lens goes on and it's bearing on the cornea, you don't know exactly how much higher you need to go. So you have to put another diagnostic lens on to see what lens clears the cornea and by how much apical clearance exists. So better to put on a higher depth than you think you need rather than a lower depth. If you're going to use the 15.5 because your horizontal visible iris diameter, your corneal diameter is smaller, then you're going to start with the 3,400 for normal, 38 for diseased, or the 42 for a transplant. So this gives you an idea of how to start. Really simple. The vast majority of the time, these 3 trial lenses are all you need in your fitting set. But of course, the fitting set is much broader than that. Now, if you look at the sagittal height usage of the 16.5 millimeter smart lens, you'll notice that a high percentage of the patients fall within about a 4,000 and a 4,400 trial lens. So we really don't need a lot of our smart lens trials, because we're going to be picking the same lens very frequently for most of our patients. Unless you have a really extreme eye shape, then a very low percentage of the time you're going to use the highest depth lens. A very low percentage of the time you'll use the lowest depth lens. In the 15.5, it's a very similar story. Most patients fall within the 3,400 to 3,800 micron sagittal depth. And as you can probably tell, the way the smart lens is fit, it's according to height, not according to base curve. So you think about sagittal depth. How high or how low do I need my diagnostic lens? So some of the fitting considerations are, you have 4 zones that you need to consider. And within those 4 zones, they allow us to manipulate every section of the lens that we might need to alter based on the eye shape. So the first consideration is you want the lens to vault the central cornea. You want that lens to clear and protect the central epithelium. So go up or down in height to produce the optimal tear layer. Use those diagnostic lenses. If you put the 4,000 micron 16.5 lens on eye and it touches the central cornea, then go up 200 to 400 microns and see if you clear the cornea. So find the height of lens that will have the appropriate depth. You can change the base curve of your custom order to increase or decrease the apical clearance. Typically, I never I never adjust the base curve. I use the outer zones of the lens to change the apical clearance, but it is something you can do. You can take your 4,000 micron lens, flatten the base curve slightly, that'll reduce the apical clearance, steepen the base curve slightly, that'll increase the apical clearance. But there's an easier way to do it where you don't have to compensate for the lacrimal lens power, the SAM and FAP factor. And that's to use the second zone in the lens. The second zone is kind of like an elevator that lifts or drops the center optic zone. So we use this one frequently to alter the height of the lens. And by changing the peripheral corneal zone angle, zone 2, you can make the center optic zone drop down. If you make the peripheral corneal zone angle higher, then you increase the vault, creating more clearance over the center. So we often use this zone if we need around 150 microns more or less apical clearance. Now, the third zone in the lens is very important in that it's going to allow us to clear the limbus and protect those sensitive limbal stem cells. So we want to see the lens vaulting through the peripheral cornea and limbus, and we use this zone to raise the lens up if you have landing at the corneal border or at the limbus. So that is done by altering this angle right here. You can see on the standard trial lens, if I have a normal angle and it's relatively close to the limbus, now I create a significant change to the vaulting through the peripheral cornea and limbus. And I've rarely had to do this, if I needed less limbal lift zone, if I want to lower the vault over the limbus, then I can decrease the height of this zone. The only time I've ever had need to decrease the limbal vault, I always feel like more limbal vault is healthier, it's safer. If you need less, it's normally because we're creating conjunctival prolapse. There's so much room underneath the contact lens at the limbus that the conjunctival tissue gets pulled underneath that area of large vault where you have a tear suction force pulling on the tissue. So you can reduce the vault to reduce that suction force and that space for the lens to be pulled into. So the final zone of the lens is the scleral landing zone, and we want that lens to touch down 360 degrees. We want to see a healthy vessel flow of the large and small capillaries running right through the edge of the lens, telling you it's a healthy landing. So if the lens is angled toward the eye surface, then it's more likely to impinge on the eye, on the conjunctival surface. If the lens lands and matches the angle of the surface, so if your contact lens landing angle is equal to or parallel to the underlying surface it lands on, then you should have a very good relationship, and we shouldn't see any blanching or any signs that the lens is steep at the lens edge. Okay, so you have 4 different zones in the smart lens. The center zone is available in 200 micron increments in your fitting set. The second zone, if you make a 1-step change, that equals 25 microns. So if I make the peripheral corneal zone +1, I'm increasing the sagittal depth 25 microns. If I make the peripheral corneal zone -1, I'm decreasing the sagittal depth 25 microns. If I make the limbal vault +1, I'm increasing the vault 25 microns. If I decrease a negative limbal lift zone adjustment, I'm decreasing 25 microns. And then the same thing with edge lift in the scleral landing zone. If you increase the edge lift, then that's a 25 micron change to the sagittal height. So all of the adjustments are that you make to the outer 3 zones, 1 step equals 25 microns. Now, it's not very typical to change the lens by 1 step. In the landing, you might, but in the other zones, in a scleral lens, you typically want bigger jumps. 50 microns would be a minimum. You normally change the lens by 100 microns to see a noticeable effect. So a 4-step adjustment, 4 times 25 microns, 100 microns. So just in summarizing this section, when you diagnostically fit the smart lens, place the lens on, make sure it doesn't have touch. Go up or down in height to ensure the lens will clear and protect the corneal tissue, so you can't see any thinning of the fluorescein pattern. Then at the limbus, make sure the lens is clearing and protecting the peripheral cornea and limbal stem cells. If you have a thinning that's less than 180 degrees, normally that's not a problem. That's just the lens decentering slightly. The Smart Lens team can share with you some of the tricks to confirming whether you have a lens in bearing with the surface or that it's just a thinner pattern. If you have more than 180 degrees of thinning or touch, that's when I would lift the limbal lift zone, the 3rd zone, by 4 to 5 steps to ensure that we're clearing and protecting the tissue. Then in terms of the landing, that's the last thing you want to look for. All of these things observed after the lens settles, because if you rush to diagnose the fit of the lens and the lens hasn't had its time to sink into the conjunctiva, you may be making changes that you shouldn't. So the only thing you can really observe right up front is the lens touching the central cornea? Do I need a higher sag lens? Then you can also make an asymmetric landing with the smart lens. If there's ever a point that you have a varied elevation around the clock, that's something you can do. You can also make the smart lens with multifocal optics. If you have a scleral lens patient that also needs a presbyopic correction, then that's something we can do. The surface uses tangents And this is a very odd concept, but a tangent is a straight line surface. And that's because the underlying peripheral cornea and limbus is much more tangent in shape. There isn't a curve to the eye surface outside of the central cornea. So the Smart Lens uses tangents in its construction, and that's what makes it so forgiving and easy to fit. It also uses a toric landing as its standard way to align to the scleral surface. That also helps because you have better alignment with the eye surface. You have less blanching, less tightening, but also less fogging because the lens distributes its pressure evenly all the way along. So the Smart Lens is a scleral lens that you can fit on virtually any eye surface. Really, there should be very few eyes that you can't fit with this lens. We've had a few, I'd say probably 3 in the last 10 years, where 3 patients where we needed an even bigger lens. We needed a very odd scleral lens. But otherwise, the vast majority of our patients we can fit with a Smart Lens at 15 millimeters diameter, 15.5, or the most commonly used, the 16.5 millimeter diameter. So you've got a couple options. I hope this has been helpful. Before Dr. Damati comes up and shares this case with us, I'm really excited to hear it. I hope that this description of the irregular cornea and the varied approaches that we have will help. So Spectrum International can be a real resource. The experts like Ricardo Duarte are so great at understanding how to manipulate these lenses to optimize the fit. So I'd encourage you to use the resources that you have available to you to assist with the fitting. So Ricardo, maybe I'll pass it back to you and we can transition over to Dr. Damati.
Yeah, for sure. Thank you. Thank you for your kind words. Thank you for the presentation, Randy. It was really, really interesting. I know for sure we're going to have some questions later on. So yeah. So Dr. Damati, are you ready?
Yeah, thank you, Dr. Randy, for this informative lecture. And I will share now my case reports, which I had last June.
Are you sharing your screen?
Yeah, I think here. Okay.
Yeah, there you go.
Okay. This is a case report. One of my case report practices I would like to focus on. I received a patient referred to me from eye care center, famous eye care center, last June, and yes.
Can you share, put the presentation, click on the presentation button down below so that we can see what bigger?
On your screen.
Down.
Down.
Point your cursor down where it says comments. Go at the bottom of the screen where it says notes, comments, and then you have some icons bottom of the screen.
Okay, at the bottom of the screen, share now.
No. On your presentation, you have, yeah.
Okay,
at the bottom of the screen.
And now?
Oh yeah, there you go. There you go.
All right. This is a case report. I would like to present it and share it with you, dear doctors and colleagues. This case description now, as I received a 51-year-old female complaint from unilateral anterior regurgity with penetrated keratoplasty referring to me from to my clinical practice last June. It was she was referred to me from eye care center, famous eye care center in Amman. to try to improve her vision and to reduce the headache and blur. The right eye she was suffering from history of keratoconus, and she was transplanted a cornea for the past 12 years. And the best visual acuity corrected was only zero point 0.1. The patient was really upset and unhappy with this result. And the left eye was managed with the glasses. It was normal, and she was visual acuity 1 point with the glasses. Actually, the patient came still in my clinical practice, frustrated as she tried in eye care centers to manage her case with this visual acuity, but with no good result. Actually, we received the patients and we expressed to her that we have the latest generation of lens invention, and let us try a session that we can understand your case to achieve this visual correction with this comfort. And during my evaluation, of course, I would like to emphasize all eye care centers and optometrist eye care practitioners to use their best devices in terms of evaluation these cases, like slit lamp is very important, and your ARK, retinoscope, and topography if you have. After I evaluate the patient objectively, I try to start to use my tri-diagnostic lens with the diameter of 15.5 with a sag of 3800 and base curve 8.04 with Torque H design. And the lens trial set was the power plan. The lens was stable, comfort, and the patient expressed her happy for the comfort and satisfaction, as well my observation. During my slit lamp observation evaluation, I'll show you the figure, how it reflects and show how the side evaluation. The following was noticed as the central apical zone was flat with low side as 3,800 at 100 microns. So after 30 minutes from the evaluation, I found only the clearance, central clearance, only 100 microns. And the mid-peripheral was settled with 200 microns. The limpal part was appropriate with 75 microns. The landing part was well aligned horizontally flatter than vertically. That means the eye shape of the patient, because the lens was stable and reflect the comfort of the patient. Actually, the patient was she was really surprised for the comfort, and she was more surprised when her vision improved. I made certain changes as we said at we have only clear central clearance 100 microns, so I increased 100 microns at the central zone, which is you can see here this figure and image. You can see the BKB line and the lens with the fluorescent button reflected clearance. But if you go by scattered image, you can find that clearance is quite poor. Because of that, we increased the central clearance with 150 microns for patient safety. As you can see here, the best fitting achieved for the adjustment. And after that, I made the over refraction with the lens, and it was minus 5.25, and the final lens was minus 12.75 after. The visual acuity was improved up to 0.9. Actually, the patient was really surprised when her visual acuity improved this much, and she was looking once to me and once to the chart, how my vision and comfort was achieved in your place. Of course, you have to express to the patients you have the good skills as an optometrist and contact lens fitters, and you have all the options with best materials to provide for your patient. The patient was really satisfied and she came frustrated, and she was really happy to order balance, and she was eager waiting for balance to receive and to use it. So we changed patient life, patient vision, patient comfort, patient reality. And of course, don't forget to focus on balanced material for these cases, especially for the PKD cases. You need a very high oxygen fluxing to avoid any expected mechanical complications like hypoxia, corneal edema, and you have to understand that the fluid counting cells should not be less than 750 or 800. And after that, during our sessions, moments, I really exceeded patient expectation in terms of vision, comfort, which she had lost the past 12 years. The patient was so happy to receive balance. And finally, we transferred the patients to the training sessions to understand and to train her how to insert the lens, take off the lens, remove the lens, and the proper solution to this. I would like to make sure for three most important criteria to put in mind and to do fitting these lenses as smart lenses, as a modified generation lens. The first criteria, the three important parts. The first one is the lens parameter. Make sure you are doing correct lens parameter, and then the sag, mid-river, land ball zone, and the landing zone. The second part, the refractive power. Make sure to evaluate the refractive power correctly. And the third part, provide your patient enough chair time to give them the training session in terms of insertion and removal as well. At the end of this cycle, if you achieve it all well, you will be having a great success story in fitting these lenses and patient reality. So the patient, of course, she will get back to the clinic, who will refer her to you, and she will tell the success story, and you will be having a success story work between the eye care centers, patients, and field practice. Thank you all.
Thank you, Dr. Damari. That was a wonderful case that you resolved with the Smartlens. Great to see that. So if you have questions, please write it down. I know Randy and Dr. Damari are more than happy to answer them. So we will give about 10 minutes to answer any question. So please feel free to write it down. So let's see. You can ask about KBA or Smartlens, whatever you want. So I have two attendants that want to talk. I'm gonna let them because it's kind of a okay. Let's see. Dr. Karan, you can speak. You can talk. Dr. Farah. Do you want to ask a question? Dr. Farah? We can hear you, but it's far.
وانا بلف ايدي رافعه على طول سبيكر
Dr. Damani.
Yeah, Ricardo. Yes, Ricardo. I think I have a colleague, Maha. She wanna ask a question. Okay. Can you open her mic, Maha? Asaf?
Okay. Yeah, sure.
Maha Asaf, a colleague, and she's preparing for her master in advanced nanotechnology and materials, and she's practicing also taking Smartlens.
Yeah, she's able to talk, or Dr. Maha is able to talk.
Okay, it's an honor to be here with Mr. Randy Kojima and Dr. Nizar. Thank you for the presentation that you offered for us today. I would like to introduce myself. My name is Maha Asaf. I graduated from Just University as optometrist and continuing my master degree thesis in it. And I would like to ask about the fogging, because in our clinic, there's some patient who coming after maybe 2 weeks suffering from fogging, and there's many reasons. One of them is the limbal limbal zone and the landing zone. How could we treat it?
Ricardo, did you want me to tackle that?
Yeah.
Okay. Hey, great to meet you, and congratulations on your master's path. That's so exciting.
Thank you.
The fogging, as you probably know, we really don't know the cause of it. We know that it has the highest concentration of lipids relative to everything else. So why is that? What I can say is we've seen a big change in the volume of fogging patients when we have a appropriate landing. And since switching to a toric landing lens, that's really helped with the fogging. So that's something I might try. What you can do to determine if you have the right relationship with the sclera is put the scleral lens on without fluorescein. So no fluorescein behind the lens, no fluorescein in the eye. Then set the patient up behind the slit lamp and observe make sure your magnification is right, everything is in focus, and then tap a fluorescein strip to the front of the eye and immediately observe, do you see fluorescein getting in somewhere behind the lens? And often if for instance you have a toric smart lens on eye, if the fluorescein comes in where the markers are, the flat meridian scribe markers, that means the lens is landing heavy on the steep axis, but it's lifting on the flat axis. So we have too much toricity. If the fluorescein comes in opposite to the markers, so let's assume the markers are here and here, and the fluorescein is coming in at 12 and 6 o'clock, that means that we have inadequate toricity. So those are some of the ways that we might try to determine if the lens fit can be adjusted to eliminate the fogging. Now, if we've tried everything with the lens fit, reducing the apical clearance, adjusting the landing, then we might put the patient in a situation where they fill half the bowl with saline and then half the bowl with preservative-free artificial tear, and that thicker, more viscous artificial tear can sometimes keep the lens from fogging. Sorry, I said that in reverse. The first should go the preservative-free artificial tear, and then on top of that, then place the saline, and then hopefully when the patient applies the lens, they squeeze out more of the saline and leave the preservative-free artificial tear in the bottom. But limbal vault is something to look for. Is it excessive? Is it inadequate? Those are some of the other things that you might try. But fogging is simply a problem that in scleral lenses, it's kind of the Achilles heel. We haven't figured out exactly how to address it. I just can say that for us at the university, it's been a huge change going to a toric landing. That's almost eliminated fogging altogether. It's been incredible how just using a toric landing has changed how often patients fog. I hope that's helpful.
Thank you, Randy.
Thank you so much. Mr. Randy, I want to ask another question also. How can I made a wise decision to choose the material that I should for many patients or for the cases?
For your scleral lens fitting or corneal GP or just in general?
No, for the fitting. In general, if I want to choose a specific material for a specific patient, what should I depend to choose? There's a Contamac, there's a Boston. Maybe sometimes I'm confused. I don't know what should I use for some cases, maybe.
Yeah, it's a very good question. Personally, I find very little difference in the 100 DK materials, the HDS 100, the Equilens, the Boston EXO, the Contamac Extreme, or Extra and Extreme. So really, I don't find a huge difference between the materials as far as their performance. There are some that will flex a little bit more and some that will scratch a little bit more than others. So I might try to steer away from lenses that might induce astigmatism, that might flex too much. And I tend to have my favorites that way, that seem to be more consistent in wetting, more consistent in their maintaining their parameters, not scratching, not warping. Ricardo, what is your experience with Smartlens, and what material are you using most with it? And is that lens been performing well in terms of scratch resistance and wettability and such?
Yeah, so whenever you want to I mean, the most common material is either the Extra or the XO. I mean, by the angle of wettability, I mean, as you may know, Randy, and I know you know, the Boston has it depends more on a coating rather than the Contamac Extra. So to maintain the wettability, I mean, for durability, I would assume Boston is has better durability in my experience. But whether to choose one or the other, I would depend basically on the DK mostly. When having the type of cases that you may have, I mean, a PKP, I would rather increase the DK. And it can go either with, because both of them has 100, I mean, the Extra or the XO, or you can go higher with the XO2 or the Extreme with a 141 DK. I mean, but it would depend on your I mean, by company, whatever you feel most comfortable with.
Yeah, it's such an interesting question, because the GP materials are inherently inert, and none of them allow anything through them other than oxygen. So as far as performance goes, they're all so similar. Really, we shouldn't see a difference between lenses other than how much they flex, how soft they are, how much they will allow for scratches and warping. But having said that, I think it's very interesting that we have patients that pop up where we might use the lens material we use all the time, and they react to the lens in some way. And simply by switching materials, we end up with a better outcome. And so it almost seems like patients can be allergic to specific materials, which doesn't make sense, again, because they're so inert. But there will be times, I guess that's the point. There will be times when switching material will help.
Yeah, but I think it's most of the times it could be like for the angle of wearability. So that could make a difference, and just having the coatings as well could help with the comfort of the patient, which is ultimately what you're seeking for. That the patient feels comfortable with the material, and you can provide the oxygen, like Randy was saying, and you have both of those companies having the same exact oxygen flow. So yeah.
Yeah, you know, in my clinical practice with the lens material selective, I can really do agree with you guys that Contamac could be very good for PKP as cases. And the Boston could be great also with the Hydrabid, can improve the comfort 30% than without Hydrabid.
Yeah, very good point.
And you know, the Hydrabid can minimize the wetting angle for the lens. So all my patients, I was having experience with my case. Victor, she's a dentist in the US, and she used to Contamac without Hydrabid. And when I changed, and she was having a severe dry eye, and she was moderate happy. And when she came back for fitting session, I changed the material for Boston XO2 and with Hydrabid to minimize full body awareness, and she was extremely happy with the this material.
Yeah, so Dr. Abdul Raham Ali had his hand up. I don't know if you want to ask a question. You are permitted to talk. Please, if you have a question, let us know. If not, then we will conclude. Oh yeah, so he's raising up again. So do you have a question, Dr. Ali?
Hi.
Yeah, hi.
My question, I can use normal saline with versatile solution in scleral lens fitting, because normal saline with very versatile not present in my country.
Okay, Randy, you want to take that?
Sorry, what was the question, Ricardo? I had a little bit of hard time hearing.
If he can use normal saline, that was your question, right, Dr. Ali?
Yeah, with the versatile normal saline, not very versatile solution.
So which one do you get on your country? The preservatives free or or with preservatives?
With versatile.
Okay, so yeah, so he's asking if you can use normal saline with preservatives or scleral lens.
Yeah, when we fill the bowl full of fluid and we place it on eye, and that patient wears it a minimum of 8 hours, probably more like 12 or 16 hours, or maybe even more.
Yeah.
Very little of that fluid behind the lens gets exchanged. We've studied this out pretty conclusively, that basically what you start with in the beginning of the day, you're probably going to end with at the end of the day. That lens seals itself off 360 degrees. So that means that if we put a fluid with preservative, if we haven't cleaned off the conditioning solution and the preservative is behind the lens, or we fill the lens bowl with any kind of preserved fluid, that potentially will create a keratitis that we're going to be, eating away at the cornea, because that there isn't any fluid exchange. If there is, it's very, very little fluid exchange. So if you can find something that's safe in that environment over the course of hours and hours and hours, then you can use it. So if you're really struggling with preservative-free saline, like inhalation solution is one that that we often use because it's readily available from the pharmacist, and Spectrum can send you the prescription for that, so you know what to look for, the product code as an example. Or in a worst case scenario, it's very expensive, but in a worst case scenario, we could use preservative-free saline. Sorry, preservative-free artificial tear. My apologies. So I know that's a hard one. If there's some way to get a fluid that's preservative-free and appropriate for application behind that lens for hours and hours, that would be optimal. Anything with preservative, it's really going to agitate the cornea.
Thanks, Doctor.
Okay, Randy, I might ask my colleagues in the region in Arabic to have any question in Arabic they would like to ask.
Yeah, please.
Yeah.
Please.
زملائي الكرام، إذا في حدا عنده سؤال بالعربي بحب يقول لي إياه أو أنقله إلى الزملاء نجاوبكم عليه بالعربي، نحن حاضرين. Both Arabic and English are available in this presentation. تفضل.
دكتور.
نعم تفضل. مين معي؟ عبد الرحمن.
دكتور، سؤالي على في الكونترا انديكيشن في السكرير لينسز، كم اقل ثيكنس ممكن اشتغل عليه؟ يعني انا بحثت في الموضوع الكونترا انديكيشن بالنسبه للثينست الكورنيا، كم اقل كورنيال ثيكنس ممكن اشتغل عليه؟ يعني اذا جانا بيشنت عنده 230 thickness
Okay, Abdurrahman asking for what is the limitation of the corneal thickness we can fit these lenses. We wish to answer as long as there is no corneal opacity, you have a clear cornea, you can go ahead. This is my.
Yeah, Dr. Damati, absolutely.
عبد الرحمن، تقدر تشتغل على أرق كورنيا طالما ما فيها خدوش، تمزقات or high drops, scars، تقدر أنت تشتغل على. بالعكس يعني تعطيك سيفتي لأنه ما تلمس القرنية، وبتعطيك أمان إنك أنت تعمل over reflection، تعمل فحص تساقط. فهي أكثر عدسة مناسبة حتى في الكونتاكت. تمام عبد الرحمن؟
على أي thickness دكتور أقل؟
ما في يعني طالما القرنيه ما فيها خدوش وما فيها تمزقات تقدر تشتغل عليها، ما في ليميتيشن.
ثانك يو دكتور، يعطيك العافيه.
I think just to add to that, the challenge that we face with scleral lenses, as far as contraindications, are transplants that were low endothelial cell count, that really anything we put on eye starves the eye of oxygen, and that would be the biggest concern I think that exists with scleral lens fitting. If we are limiting the oxygen supply to an eye that really needs it, that the cornea is almost expired already, that would be the biggest concern that we have in scleral lens fitting, and just making sure if we fit that transplant that they're getting enough oxygen.
Absolutely, very true. عبد الرحمن، الدكتور راندي بيحكي زي ما كنا نشرح بالسلايدز، عندي بالحاله اللي انا عرضتها زراعه القرنيه، بدك تتاكد ان الانثيليال كاونتنج سيلز مناسبة لا تقل عن 750 إلى 800 علشان ما تواجه مشاكل بميكانيكال كومبليكيشنز لايك كورنيال اوديما ولا يصير في عندك تشالنجز في الكورنيال.
ثانكس دكتور، يعطيكم العافيه.
عبد الرحمن، انت من فين حضرتك؟ لان سمعت انه ما في عندكم سلاين بريزرفاتيف فري اي بلد؟
والله عندنا في اليمن عندنا المشكله كل النورمال سلاين الموجود عندنا كله مع مواد حافظه.
اوكي، معناته ممكن
غير متوفر يعني، حتى في الصيدليات ما موجود، وطلبيه احنا بنعاني
اوكي. بتقدر تستخدم اللوبريكانت بريزرفاتيف فري بتكون مناسبه.
ممكن. يعطيك العافيه دكتور.
Anybody else أو في حدا تاني في عنده سؤال لدكتور راندي، دكتور ريكاردو أو لإلي أنا شخصي؟ إحنا حاضرين نجاوبكم، نشارككم يعني ملاحظاتنا وكيس ريبورت تبعتنا أو let us know your.
Actually, there is a question from Dr. Lara Bou, and it says, is there any study about complications due to no tears exchange behind the scleral lens? If yes, can I have the DOI or the title of the study? Do you know something about that? And that may be our last question. I don't want to take that much time of Randy. So Randy, do you have any study?
No, we don't have any study that suggests that the lack of tear exchange is a concern. Interesting, because you would think we've been trained that every contact lens needs to move, every contact lens needs to exchange fluid. I think a corneal GP exchanges 100% of its fluid within 5 to 7 minutes. A soft lens, I believe the study indicates that it takes like 30 minutes, I think it was. Forgive me for not remembering 100%, but it's even soft lenses exchange a lot of their fluid within a relatively short period of time. But a scleral lens, we can put fluorescein underneath the lens and then send the patient away for 8 hours, and they have the same apparent volume of fluorescein behind the lens after 8 hours of wear. So it appears that with this huge volume of fluid, maybe that's the difference, that there's so much fluid behind the lens. If it were thinner and not exchanging, it might be more of a problem with metabolic waste buildup, but possibly because it's so thick, it's less of a concern. But yeah, it's really kind of amazing that we can fit these vaulting scleral lenses that seal themselves, as they sink into the conjunctiva. Their seal is even more significant over the course of the day. But really, I can't think of any studies that suggest that that lack of tear exchange is a problem. There are other things to consider. The oxygen permeability of both the material and the fluid is a concern, as we talked about in the corneal transplant. That's one that we have to keep our eye on in any transplant patient, and of course all patients. But oxygen permeability doesn't seem to be issue in 99% of non-transplant patients that we fit. Another concern would be IOP, the intraocular pressure. When you put a lens on with that fluid layer behind it, the fluid layer has a suction force, and that suction force appears to raise IOP. So is that a worry over time? We really haven't seen, after 20 years of the modern scleral lens, any issues, but that would be one that we might keep our eye on long term. But oddly enough, not the tear exchange, which is interesting.
Yeah, okay. Well, so Randy, Dr. Damari, I want to thank you for your time. You're being so kind to share your knowledge. I appreciate it so much in the name of Spectrum International. We are pleased to have you here with us. Everyone, thank you for being with us this day. Hope you enjoyed it. I know I have. I know I keep learning from Randy every single time. So thank you so much, and see you soon. Bye-bye.
Thank you, Randy, and thank you.
Thank you, everybody.
Okay, thank you, everybody. Enjoy your night. Thank you.